Hey everyone, and welcome to this rapid review explainer. Today we're targeting a seriously high-yield topic for all you med students and focused learners out there: obstructive lung diseases. We're going to aggressively tackle the COPD umbrella and definitively separate it from asthma. Let's just dive right in, because nailing these clinical nuances is absolutely essential for your exams and, of course, your future practice. Our clinical workflow today looks like this. First, intro to obstructive diseases. Then we'll cover classic clinical presentations, asthma triggers, key diagnostic investigations, and wrap up with first-line treatments. Basically, we are tracing these diseases from their underlying pathology straight into the lab results and pharmacology. All right, Section 1, Intro to Obstructive Diseases, focusing specifically on the permanent damage of emphysema. It's actually fascinating when you think about the underlying anatomy, because it perfectly explains why we use the words chronic and obstructive. If you compare a healthy alveoli to an emphysematous lung, the difference is wild. In emphysema, there's this permanent enlargement of the air spaces, and the walls themselves are destroyed. The fragile tissues between the alveoli are literally gone, leaving these large, useless pockets where air just gets trapped. And because this damage cannot be repaired, it's a chronic, ongoing state. That trapped air completely blocks the smooth flow of fresh air in and out, making it obstructive. So what's actually causing this irreversible destruction? Well, by a massive margin, the primary culprit is smoking. People who smoke are about 6 times more likely to develop emphysema. The smoke basically irritates the airways and destroys the cilia, those tiny hair-like structures that are supposed to clear out mucus. Without them, the mucus just builds up and that classic shortness of breath sets in. But wait, here's an absolutely crucial high-yield board fact you cannot forget: alpha-1 antitrypsin, or AAT, deficiency. AAT is a natural protein that stops your white blood cells from damaging your own normal tissues. If a patient is deficient in this, their own immune response can lead to profound lung damage and emphysema, even if they've literally never touched a cigarette in their life. Let's quickly step through the 4 progressive stages of emphysema. These are based strictly on lung capacity percentages. We start at stage 1, mild, where capacity is at 80% or more. Then we drop to stage 2, moderate, which is 50 to 79%. By stage 3, severe, that capacity plummets down to the 30 to 49% range. And finally, stage 4, very severe, hits when capacity drops below 30%. It's a really harsh, progressive decline if the underlying causes aren't managed. Okay, moving right into Section 2, classic clinical presentations, spotting the phenotypes. We're looking at one of the most classic dichotomies in all of medicine here. How do these pathologies actually look when a patient walks into your clinic or pops up in an exam vignette? Think about the classic blue bloater, which represents chronic bronchitis. You've got the characteristic overweight presentation, cyanosis, which gives them that bluish tint from hypoxemia, and peripheral edema. Then contrast that with the pink puffer of emphysema. This patient is typically older, very thin, breathes through pursed lips just to keep their airways open, and has that classic barrel chest because of all that trapped air we were just talking about. Now, even though they look entirely different, remember that both of these actually fit right under the COPD umbrella. In fact, they frequently coexist in the exact same patient. The core difference is really anatomical. Emphysema is the physical destruction of the air sacs, causing severe shortness of breath even when the patient is just resting. Chronic bronchitis, on the other hand, is fundamentally an inflammation of the lining of the bronchial tubes. That's why it presents with that hallmark, frequent smoker's cough that's just loaded with mucus, along with chest tightness and pain. All right, Section 3, asthma triggers and symptoms, the reversible counterpart. So unlike the permanent alveolar destruction we see in COPD, asthma is a whole different ballgame. It's characterized by airway hyperactivity and inflammation that is actually reversible. A huge clinical clue here is the presentation of a very distinct diurnal pattern. That means symptoms like coughing, wheezing, and chest tightness often get way worse in the early morning or late at night. The patient might present with tachypnea, tachycardia, and you'll visibly see them using accessory muscles to breathe. And the triggers? They're all over the place. Cold air, physical stress, exercise, and yes, even NSAIDs like aspirin can set it off. Let's jump into Section 4, which is really the absolute core focus of this review: key diagnostic investigations, proving the pathology. Okay, imagine you're in the clinic. A patient comes in presenting with shortness of breath and wheezing. Both asthma and COPD share these exact same symptoms. So how do you definitively diagnose and medically differentiate these conditions in the lab? Well, we start with pulmonary function tests, or PFTs. What you're hunting for is an obstructive pattern. You're going to use spirometry to evaluate the exact airflow limitation. If you order a chest x-ray, particularly for an emphysema patient, you'll see hyperinflated lungs, a flattened diaphragm, an increased anterior-posterior diameter, that's that barrel chest showing up on film, and a smaller tubular-looking heart. You'll also rely on arterial blood gases, or ABGs, to assess exactly how efficiently oxygen and carbon dioxide are being exchanged in the blood. But here is the absolute crucial differentiator, the methacholine challenge test. Because methacholine is a bronchoconstrictor, an asthma patient will test positive, meaning their FEV drops by 20% or more because of those hyperactive airways. But in a COPD patient, the FEV doesn't really decrease because their obstruction is purely structural, not hyperactive, it's fixed. Now flip it around. If you give them a bronchodilator like albuterol, an asthma patient's FEV will increase as the obstruction reverses. But that COPD patient, again, they'll show a fixed obstruction with minimal to no change. And that brings us to our final part, Section 5, First-Line Treatments and Pharmacological Management. When it comes to managing COPD, rule number 1 is always smoking cessation. It's absolutely essential if you want to have any hope of halting the disease's progression. But for the pharmacological side of things, your absolute first-line therapy is bronchodilators, specifically beta agonists and anticholinergics. You can also throw in inhaled corticosteroids to help bring down the inflammation, and for those patients dealing with persistently low blood oxygen therapy is utilized. Now, what if that COPD patient comes crashing into the ER with an acute exacerbation? Maybe they're showing cyanosis and heavily using accessory muscles to breathe. Your immediate protocol here relies heavily on short-acting bronchodilators. Think an anticholinergic like ipratropium paired with a short-acting beta agonist, or SABA, like albuterol. And here is a massive, high-yield clinical pearl for you. When administering oxygen therapy, you only target 24 to 28% oxygen. You just want to maintain their saturations right around 92%. You do not want to overshoot it. You also hit them with oral or IV steroids and antibiotics like amoxicillin or azithromycin just to clear up any underlying infection that might have triggered the flare-up. Now, treating asthma relies on a slightly different paradigm. Here, we split the medications into two main camps: immediate symptom relief versus long-term controller medications. So for a patient presenting with mild asthma, meaning their symptoms are popping up less than once a week over a 3-month period, and they've got fewer than 2 nocturnal symptoms, you simply prescribe an inhaled SABA, like albuterol, to be used purely as needed. It's pretty straightforward. However, if you need to establish long-term preventative therapy for more frequent, bothersome symptoms, you keep that SABA on hand for emergencies, but you add in a daily inhaled corticosteroid, like beclomethasone, or a leukotriene receptor antagonist, like montelukast. To summarize everything we've quickly powered through today, I want you to remember this core distinction. COPD damage, that alveolar destruction, and the trapped air is permanent. It requires strict management to halt progression and control symptoms. Asthma, on the flip side, is a reversible airway hyperactivity. That is the fundamental difference that drives every single part of your diagnosis and your treatment plan. All right, let's leave off with a final clinical scenario to test your instincts. If a patient presents with an obstructive PFT pattern, but they show absolutely no FEV decrease during a methacholine challenge, what is your next step in management? Think about what that fixed obstruction actually means. Think about those first-line bronchodilators we discussed. And think about having that tough but necessary conversation about smoking cessation. Keep reviewing, keep connecting the underlying pathology to the clinical presentation, and I will see you in the next explainer.